This is FTCC News from Winston-Salem. I'm Mackenzie Matthews, here with the ADN program. We start this morning with news from community nursing school students who have reached out to local hospital nurses in regards to safe nurse-patient ratios. The current COVID-19 pandemic has had its own effects on the ever-growing staffing shortage. These nursing school students have sought to put LPNs back into practice in acute care settings. Reporting to you live from Forsyth Technical Community College with more on the story, Chelsea Oswell.
Thanks, Mackenzie. I'm at Forsyth Tech now. We have conducted a survey amongst various nurses in the major hospital systems in the Triad area, Atrium Health, Novant Health, and Cone Health. Results found that most nurses agreed that the nurse-to-patient ratios are unsafe and puts both the nurses and the patients at risk. One nurse stated that the current nurse-to-patient ratio is absolutely not safe. Current results also show that nurses are open to the idea of licensed practical nurses helping and working on their units. According to a national study based on the effects of nurse-to-patient ratio legislation on nurse staffing and patient mortality, mortality rates were not significantly higher at baseline in comparison hospitals, but were significantly lower than at baseline intervention hospitals. In addition to producing better outcomes, costs avoided due to fewer readmissions and shorter length of stay were more than twice the cost of the additional nurse staffing. Us students at the ADN program seek to improve patient outcomes with a decrease in risk for things like readmissions and failure to rescue. We seek to improve nursing satisfaction and optimize the working environment for our nurses. Finally, we seek to bridge the gap between the staff perception of support from management and their leaders. With more information on how we will implement our plan, here is Cassidy South.
Thanks, Chelsea. Using a quality improvement framework known as PDSA, or Plan, Do, Study, Act, our plan is to implement licensed practical nurses on various units in the hospital and compare the efficacy of that implementation to units who do not have LPNs. We would like to implement LPNs in acute care settings such as intensive care units, med-surg units, and orthopedic units at one hospital and compare them to another triad hospital where we did not implement them. After a quarter of the fiscal year, we will study the effect that the LPNs had on those units based on patient outcomes, the number of readmissions, and RN satisfaction. If outcomes are desirable, our goal would then be to implement licensed practical nurses in areas where nurse-to-patient ratios are unsafe and acuity is high. Now on to Sarah E. and Scarlett, who will discuss more information on our implementation plan.
Thank you, Cassidy. We are here presenting the detailed plan of our implementation of licensed practical nurses in various hospital settings in the area, starting off with the roles of the LPN and RN, making sure that LPNs can perform the tasks and skills required in these hospital units that will be implementing them into practice. The global qualitative nursing research performed in 2010 addresses the relationship of LPNs and RNs and suggests that ambiguity and confusion surrounding scopes of practice negatively affects nurses in the workplace, which could result in negative outcomes for both nurses and their patients.
Yes, Sarah E. With this leading us to our next point of implementing not only the incorporation of the LPNs and RNs to work together for the well-being of both the nursing staff and patients, but to have available nursing staff resources that could enhance their knowledge, such as clinical-based learning modules that will strengthen the understanding of their scope of practice.
Absolutely, Scarlett. This will also help with nursing staff to enhance their engagement. Having LPNs in the ICUs, med-surg, and orthopedic units, working along with RNs to improve outcomes, of which include better patient outcomes with decrease in readmissions and failure to rescue.
The RN to LPN patient ratios will be determined based on acuity and unit. For ICUs, 1 RN will be assigned to 4 patients with 1 LPN. For med-surg, 6 patients to 1 RN and 2 LPNs. Orthopedic will be assigned 5 patients to 1 RN and 2 LPNs. The data collected from patient grids, patient acuity, and productivity will provide evidence of how this RN to LPN to patient ratios have been working out on the units being implemented. Also, the nursing staff satisfaction will be considered and be part of the data being collected to determine the outcome of this implementation.
Well, Scarlett, that sounds like if this goes the way everyone wants to, nursing staff will feel less fatigued or overstressed and will help tremendously with nurses' burnout and job satisfaction. And not forgetting the patient outcomes being successful as well. If we were able to make these changes, we would include an additional staff survey to measure satisfaction after the change, and we would look at the computerized system known as EPIC and refer to patient flags for readmission and mortality on discharges less than 7 days or occurring during hospital stay. And here we have with you Isabella Urgillo with our closing statement.
Thank you, Sari. It is imperative that nursing leadership understands the importance of safe staffing ratios. Not only is it linked to better patient outcomes, but to nurses' safety and satisfaction too. When the nurse feels cared for and respected, the nurse will provide the creme de la creme of care that is choicest for the bottom line that leaders fight so hard to meet. In order to meet both needs for subordinates and leaders alike, we would seek to offer competitive rates for LPNs and offer even better rates for our nurses, because as we've stated previously, the better outcomes associated with better ratios exceeds the cost of the additional staffing that we may be worried about. Staffing with additional LPNs is less than staffing with more nurses, and the evidence of improved patient outcomes with this type of implementation is overwhelmingly in our favor. Furthermore, staff would be more likely to stay in their respective units, feeling happier in their working environment and thus eliminating shortages throughout the triad. In a carefully constructed approach, communication between leadership and subordinates would look like addressing budgeting concerns, producing a clear outline of grid matrices for patient acuity, number of patients to RNs and LPNs, mitigating the confusion associated with scope of practice with additional training, and finally, we would be fostering a better relationship between all involved in these organizations. From the top to the bottom, horizontally and vertically, the intra-healthcare system that is nursing as we know it would be better for it. Reporting to you from Winston-Salem, have a great day.